For the past 9 years, Dr. Fred Cerise has been a central player in Louisiana healthcare. For 4 years, he served as Governor Kathleen Blanco's secretary for the Department of Health and Hospitals. Then for the next 5 years, he served as LSU Vice President for Medical Affairs and Education. In that position, he had responsibility for the university's 2 medical schools and the 10-hospital system that is the primary vehicle for providing care to Louisiana's uninsured population. He was relieved of his administrative duties at LSU in late summer of last year when he refused to embrace and champion Governor Jindal's cuts that will essentially dismantle the LSU hospital system as a result of Medicaid cuts ordered by the federal government in July of last year. While still in his position as head of the LSU system and after the cuts had begun, Governor Jindal and the LSU Board of Supervisors refused to allow Dr. Cerise to testify before members of the legislature about what he thought of the cuts and the impact on the system. In January, Dr. Cerise, who's still an associate professor of surgery at LSU, agreed to sit down with Forward Louisiana for an interview in Baton Rouge. In that interview, he spoke on the record about changes being driven through the LSU hospital system, the risks that poses to patients and the state, and the impact that will have on the cost of care and access to care in Louisiana. For starters, Dr. Cerise made clear that Governor Jindal had other options available to him rather than concentrating the brunt of the Medicaid cuts on the LSU hospital system.
The precipitator is the change in the federal matching rate in the Medicaid program. The assumption was the state didn't have anywhere to go except the LSU hospital system. The truth of the matter is the LSU hospital system makes up about 12 to 13% of the overall Medicaid program and got about 67% of the impact of those FMAP changes. And so clearly there was a very disproportionate hit to the LSU system as a result of those federal match changes. And so I believe the changes to the LSU system were not the only places to go to deal with that change in the federal matching rate.
So this is a more conscious decision to target the LSU hospitals.
It clearly is a policy decision of the administration. There certainly are other options than to put the entire or the lion's share of that impact on the LSU hospital system. What you're seeing is a policy decision by the administration. The reductions in the system were done administratively and outside of the legislative process, and so we were looking at how to deal with these cuts. The instructions that we had received from the administration and I had received from my board through the administration was to make the maximum amount of cuts that we could do that did not close an emergency room, did not close a hospital, and went up to 34.5%, under the 35% threshold. Any one of those 3 things would require legislative authority. And so these were administrative decisions. It's interesting that the decisions were made within a couple of months of the legislative session in which the legislature funded the LSU hospital system. They were concerned about the prior year cuts that LSU had to take in the middle of the year and sought input from LSU on what we would need to not have to have further reductions. And the legislature paid attention to that and so crafted a budget that would not result in further reductions to services within the LSU system, and within a couple of months these administrative actions were taken.
What are the implications of these big changes we're seeing in the LSU hospital system right now? I mean, are there particular areas of concern that the public should have?
I think fundamentally you're seeing a philosophical shift from a public delivery system to the state attempting to purchase that care and from other providers. And the concerns that I have about this shift are not that it can't be done, but that we haven't done as a state an appropriate analysis to understand, one, what are the goals that we're trying to achieve? Are we trying to get better quality? Are we trying to get lower cost? Are we trying to get greater access? That's not been really clearly defined. Are we trying to get a better environment for medical education? Those things haven't been clearly defined, and therefore not studied appropriately to see how are we going to achieve those goals. So if the goal is better access for medical education, then you would expect that your medical education experts would plot a strategy, much like you would do a major curriculum change in a medical school. You'd pull all of your leaders together, the people that know the information. You would do a process. You would involve students. You would involve faculty. But that process hasn't taken place.
More thoughtful process rather than just rush.
Right. If the goal is to lower cost, there is a lot of data. There are a lot of data out there in the literature that indicate a delivery system that a public safety net or a safety net delivery system can deliver care to a population at a fraction of the cost it would cost to insure the entire population. Health Affairs just came out with something in the past few months that looked at model safety net systems across the country, and they came to that conclusion, like others have as well. In fact, in Louisiana, after Hurricane Katrina, there was a study done that showed that the cost to insure the uninsured in the state would be $2.3 billion, which was several times the amount that's paid in the safety net system today. So if the charge is to lower cost, then the state hasn't done the analysis to show how that same level of care, same access to care, can be done at a significantly lower cost. And so, if the objective is to improve quality, same thing. We haven't seen an assessment that says we're looking at these quality indicators within the LSU delivery system today, LSU's performance on these quality indicators, and we're going to move to these systems that have these metrics on their quality indicators. That type of analysis has not been done. People are free to talk. I mean, people will tend to talk about quality of healthcare in Louisiana, and will say things like Louisiana has the highest cost and the lowest quality of healthcare. That's true in the Medicare program. We're at the very high end of cost per recipient, and we're at the low end of quality per recipient in the Medicare program in the state. Well, that care is generally not delivered in the public safety net system. That's delivered in the private delivery system in the state, which is the system that the administration is currently proposing moving the care into. And so if your goal is to improve quality to lower cost, it's not a logical step to move from a lower cost, high quality system into that system. There may be individual examples where that makes sense, individual instances where that makes sense, but we're not seeing that type of analysis to go into this planning. Instead, we're seeing kind of global generalizations that say we've got to modernize, we've got to be cheaper, we've got to do things like this, but we're not seeing the detailed analysis to back up those broad generalizations.
Who's going to provide care for the uninsured?
Right, and that's going to depend on how these partnerships are structured. We saw these memoranda of understanding, which are kind of general documents that describe the intent of the partner to work with LSU to take over the operations of some of these facilities. Just a point about that, what you're seeing from these partnerships, again, I'll go to, the state did not do analyses to look at cost of these partnership, quality of care, the access that you're going to see. At least that hasn't been described at this point in the MOU. The primary driver of these is to pull in some private funds to use as match in the Medicaid program to supplant state dollars. And so what you'll see, if you read the MOUs, they describe these milestone payments, upfront payments from the private providers that will then be used as match in the Medicaid program to draw down federal funds as a way of offsetting the budget shortfall this year. People need to pay attention to the fact that these payments are lump sum lease payments for future activity, and so it's payments now for lease arrangements that will come in the future, year or years. In the case of the New Orleans Hospital, one of the payments, a $13 million payment, is for the lease of the new facility, which won't open until 2016 or so. So we're using those future year lease payments for current year match to fix a budget problem this year in the program. And so so that's one of the issues with the partnerships. I think that's the driving issue with the partnerships, is how to allow the state to back state funds out of the Medicaid program, but still derive the federal benefit of the Medicaid program. In terms of how the uninsured are going to be dealt with, that's all going to be an issue that's got to be outlined in great detail in these cooperative endeavor agreements, which which it seems like is going to be coming as the next step, the more granular document to follow. Now, in the case where we actually negotiated one of those with Our Lady of the Lake in Baton Rouge, that was a lengthy negotiation. That process took us a couple of years to work out those details. How the uninsured would get covered was covered in great detail in those documents that we worked out with Our Lady of the Lake, where the lake agreed to take the uninsured, to take the Medicaid population. DHH agreed to pay Our Lady of the Lake to take care of the uninsured, to take care of the Medicaid population. DHH agreed to pay the physicians, the private physicians at Our Lady of the Lake, to take care of the uninsured when they were in the hospital. So all of that was dealt with in great detail in that document that took a long period of time to work out. So we'll just have to see what those documents say in that regard.
And then OK Long was open that entire time, so there was something in place at that time. It wasn't a crisis mode those agreements were hammered out.
That's correct, and in fact, the negotiations among LSU, Our Lady of the Lake, and DHH at the time, as you said, the hospital was open. Was not intended to be eliminating services in a transition period. In fact, what was described in that cooperative endeavor agreement is an expansion of services. What was acknowledged was, once the uninsured have access to services at the lake, there are going to be services that they offer that LSU didn't offer: neurosurgery, cardiovascular surgery, more specialty services. And so, modeled in the financial side of that was increased funding for access to those specialty services in Baton Rouge, and we also modeled an increase in access to services on the outpatient side as well. And so there was a significant increase in inpatient and outpatient activity that was modeled in there, not a reduction and shrinking of services.
Mm-hmm. But is this created any kind of uncertainty within the system itself as to what people's plans are?
Well, it's two things. One is you've got your existing population of students and residents who came in to a program with an understanding of what they were coming into. We're undergoing what I would characterize as equivalent to a major curriculum change. Basically, determination has been made we ought not be training in these public hospitals. We ought to be training in other places. And so, for all the people that signed up to train in the setting that we have now, we'll be changing that a lot. Generally, that is dealt with. Major curricular changes are dealt with by pulling together faculty, students, administrators, looking at, okay, how are we going to do this, getting feedback, making plans, and then over a period of years implementing those plans, right? So we're changing the rules for the people that signed up for the game today. And that does prove to be unsettling for recruiting as well. We won't know until March, when students sign up for the match, to figure out where they want to do their postgraduate training, the residency training, how that's impacting the programs in the state. But I do know that is a very hot topic of discussion among the medical students right now, and that is trying to figure out what the impact of this is going to be on the residency training.
What role does CMS play in the awarding of residency slots?
Well, CMS, they assign residency slots for Medicare reimbursement purposes to hospitals. And so hospitals have a set number. Many years ago, that number was frozen. And so hospitals that are in the graduate medical education business have a set number of slots that Medicare will reimburse for residency training. Now, the LSU hospitals, most of them have a number of those residency slots because we've been in that business for a long time, and at the time when those slots were frozen, we had a significant number of slots. I think what you see there's this chatter across the state. I've dealt with it in the past of other hospitals either trying to increase their slots CMS will not allow, generally will not allow that increase in slots because they're trying to clamp down on their exposure, funding exposure, and so they're not prone to increase those slots. If you haven't had a training program in your hospital and you start new training programs, you can get some new slots, but that's starting new training programs from scratch, not moving, not transitioning, but starting new programs from scratch. And so it's very difficult to expand the number of training slots that you have. I think you're going to see some interesting questions come up with these partnerships, and as LSU changes ownership of hospitals to private providers, what happens to those residency slots? Do those get shifted over to the private providers as well? I would contend that those are valuable state assets, those CMS Medicare funded residency training slots. And for medical schools like LSU, to have hospitals with those training slots that are critically important for your residents, that's a significant thing. Now, to give those away as part of a negotiation or a deal, I think puts the medical schools at a future disadvantage, because now you're doing training and somebody else has those Medicare funded training slots. So we're going to have to be very careful in looking at what those arrangements look like. Those CMS training slots, that's like currency in graduate medical education. You don't have to have them to do training, but you have to have them to get paid by CMS for your Medicare related business.
What would the Medicaid expansion have meant to the LSU hospital system? Was that like the path to sustainability? Clearly
a path to sustainability. We had a number of discussions internally about this. One of the things that some of the critics of the system would like to say is that we didn't have plans on how to be sustainable. But the fact of the matter is, if you look at the way the LSU system is structured today, first off, you've got the components of an integrated delivery system that the federal reformers are looking for. And so we felt like we had those components. So when Medicare starts paying differentially for, are you having good quality metrics within your hospital? Are you having problems with readmissions and things like that? We could control that better because we've got the doctors and the hospitals working together as one. And so from the delivery system perspective, we have the kind of system that you see others moving towards, trying to create scale so you can support things like big IT projects. So we felt we were on the right track there, and in fact ahead of the game there. On the financial side, we have a large percentage of the business that's paid for through the disproportionate share program, and about half of the patients in the system are uninsured patients. And what you would be doing with the Medicaid expansion is you would be moving probably 2/3 of those people from the uninsured category to the Medicaid category. Now, with the state match for the disproportionate share program is almost 40%. The state match for the Medicaid program for the expansion population, where you'd be moving the uninsured, would be 0 for the first 3 years, and over the next 3 years it tapers off to 10% state match, 90% federal. So you're moving from a uninsured DISH funded program where the state's putting up 40% to a Medicaid program where at its peak the state's going to be putting up 10%. And in that Medicaid program, Medicaid pays for physicians. The DISH program does not pay for physician services. So from the school's perspective, the physicians are providing that care. Now you have a funding source for those physicians as well. And so we had intended to have a very aggressive strategy to enroll people, to shift them from that uninsured category to the Medicaid category. It would be better for the state, better for LSU, and clearly would provide a funding source to sustain that operation. And so you would sustain an integrated delivery system that's well versed in taking care of the uninsured, provides good care, and would be able to do it at a lower cost to the state.
What happens to community hospitals as the disproportionate share goes away for the rest of the country? I mean, it's not going to be eliminated completely, but other community hospitals get disproportionate share, and some of them, particularly rural hospitals, are dependent on that money.
Yeah, and those are going to be state decisions. how to deal with that. There will be ultimately some reductions in the disproportionate share of funding for the state. I know Secretary Greenstein has said, you know, we have a big cap, and so we can absorb a cut. I don't think that's how it's going to be done. I think that the federal score is to have savings, and so they're going to take it from a baseline year of spending and give you your cut from a baseline year of spending. And so there will be some impact on the DISH allocation for Louisiana, I'm quite sure. It's going to be up to the state to determine how they deal with that. You got rural hospitals that depend upon those funds. You've got some of the state psychiatric hospitals that depend upon those funds, and then community hospitals as well, all in addition to LSU. Mm-hmm. The legislature or the administration is going to have to figure out how they want to deal with those reductions. As I said, LSU, I think we would have been in the position to absorb some reduction in DISH. In fact, would have embraced that because we would have it ensured that those people got shifted over to the Medicaid program, could take a DISH cut, and the increased funding that goes along with the Medicaid program.
But you can't do without both.
You can't reject the Medicaid expansion. You're still going to get the DISH reduction. CMS is going to make some rules around DISH reduction, and I would doubt that they would look at a state that rejects the Medicaid expansion and then protect you from a DISH reduction because you have more uninsured, because you obviously have at your disposal the option to increase Medicaid to deal with your uninsured.
All right.
The other thing about that is if you reject the Medicaid expansion, the federal government is still going to provide subsidies for people between 100% of poverty and 400% of poverty to purchase insurance. To be a graduated subsidy for people between 100 and 400% of poverty. Now, their assumption in that design is that Medicaid is going to cover, the Medicaid expansion goes up to 139% of poverty, that Medicaid would cover those people below 100% of poverty, and so you wouldn't have to do a subsidy for those people to purchase private insurance. It would be covered through Medicaid. Well, if the state rejects the Medicaid expansion, what you'll have is you'll set up a scenario where those below 100% of poverty will not be eligible for a federal subsidy to purchase insurance and will not be eligible for Medicaid, so they're going to be stuck in that uninsured mode.
Was there a particular thing asked of you that you wouldn't do that ended up with you being removed as the head of the hospital system? Well, you're free to answer. Or not. I just
in general, what my board wanted, I think, for me was to more enthusiastically embrace these changes to the hospitals. And so when I would go testify in the midst of this, when the match rate was being cut and it was being put on LSU, what I was being encouraged to do is describe that as a positive, an opportunity for LSU to modernize or transform ourselves, and I couldn't do that because we're a pretty modern operation today. If you look at what people are describing in terms of where the healthcare delivery system in the United States needs to go, they describe things as having robust electronic medical records. Well, we have a statewide electronic medical record. They look at having coordinated care from the inpatient to the outpatient. Well, LSU does that very well already. It talks about having disease management. We have disease management programs that are very mature now because we've been doing them since 1997. And a lot of metrics to support that they're being done very well. They talk about having medical homes. LSU has more certified medical homes than anybody else in the state. And so all of these things that are associated with modern delivery systems we've done and have been doing for a number of years, but the characterization was that we had to modernize, and to modernize we had to move business out of our system and put that in other delivery systems. And so I couldn't sell that because it's not true. And so in general, I think that was the issue. There other things, policy stances of the administration that clearly I didn't agree with. The Medicaid, whether or not to take the Medicaid expansion. I can think of an instance where before I had testified before committee, I was instructed not to get into the Medicaid expansion. And so when I was asked about whether I thought that was a good deal for the state to take to participate in the Medicaid expansion or not, I had to tell them, well, my board has asked me not to address that. And so I think they would have preferred if I could be, more enthusiastic about how that was a good idea, but I don't think it's a good idea. In the past, LSU had a different philosophy about that delivery system. In 1997, Merv Trail went to the legislature and made the case that it was important for LSU as the public education arm, health education arm, to have a closer connection with the public delivery system because those things are very closely intertwined. And I think LSU made a lot of progress since then in improving care in that system and improving medical education in that system. In general terms, I kept trying to make our system work in the setting of recurring cuts, and it became clear that the goal was not to make it work in the setting of continued cuts, but to have continued cuts to force transition to something else.
Right.